Hello, everyone. Thank you for tuning in. This is Psychedelically speaking, presented to you by SAPS. We meet on every third Tuesday of each month to bring you experts from multiple disciplines and perspectives to discuss psychedelic substances and plant medicines. And before I introduce our guest today, I would like to remind you that the proposals for the upcoming conference on psychedelics and spirituality, which will take place on March 28th at U Ottawa, are due next month on January 16th. If you have any questions about your proposals, you can reach out to us. And our email is sapsottawa@gmail.com. So this month's speaker is Dr. Rotem Petranker. Rotem is the director of the Canadian Centre for Psychedelic Science, and he's currently a postdoctoral fellow at the Department of Surgery at McMaster University. His research focuses on the intersection of attention, creativity, emotional regulation, and psychedelics, including microdosing, which Rotem has kindly agreed to join us today to talk about. And thank you so much, Rotem, for joining us.
Thanks, Sarsha. Thanks, everyone. It's a pleasure to be here. I'm excited to give this talk. I'm just gonna say up right off the bat, there is some new stuff that I'm sharing today that I have not presented before, so I'm pretty stoked to share this content with you. So yeah, I'm gonna start sharing my screen, just making sure you see the right stuff. Yeah, that looks good to me.
hmm
Um, Cool. So, you kind of the only thing I want to add to what Arsha already said is that I'm also a therapist, and I love that part of the work too. But yeah, I'm primarily a researcher, and that's the hat that I'm wearing today. So let's go over about the outline of this talk. So first of all, I don't know, it might not be required with this audience, but still, I want to talk about what microdosing is and why we should even care about it. I think you shouldn't just assume that it's important, and that is for reasons. Um, and then I'm going to take a moment to talk about the importance of doing good science. And when I mean good, I mean open science. And then I'll share a lot of results, basically. I'll share with you several years of research that I've been doing with various colleagues. And then I'll talk about kind of how our findings have been replicated in the broader literature. And then finally, I'll share stuff from the most recent trial that I ran with my colleagues. That is the largest microdosing psilocybin trial for major depressive disorder. And yeah, and then we're gonna have lots of time for questions. And as I said, there's some new stuff that I wasn't sure that we'd have time for. So based on how we do for time, I might present more slides at the end. Okay, so let's jump in. Why, or sorry, before we talk about why we should care about microdosing, what is microdosing? Well, there's multiple definitions out there like subperceptual, subhallucinogenic. But for at least for the purposes of the first few surveys we ran, we looked specifically at LSD and psilocybin. And in both cases, we just wanted something that's roughly 10% of what would be considered a normal recreational dose. So in the case of LSD, we were looking for something that's lower than 20 micrograms. In the case of mushrooms, we were looking for less than zero point 0.3 grams of dry mushrooms. I'll come back to the definition of microdosing later in this talk, but at least for now, this is something that we can hold on to and is quantitative. So now that we know more or less what microdosing is, at least as a working definition, let's talk about why we should care about it. First of all, there's a ton of publications on it. You can see this rising tide, very rapidly rising of publications. This is from a paper that I published with colleagues in 2020. The trend has more or less continued since. There's more and more all the time. So as people who are interested in science, we can say, well, there's more and more publications about it, so we should probably be interested and learn more about it. But as people who maybe are more practitioners or interested in it from a public health perspective, there's other reasons. One is that large doses of psychedelics, as many of you know, come with a very intense psychological experience. And that's not for everyone. And it could be due to a variety of reasons. Some people might be more psychologically fragile or unwell. They might be physically unwell, and using psychedelics often comes with some physical risks. So, for people who are older, people with heart conditions, if microdosing is effective and you don't need this very intense experience, that would be very important to know. Now, the other thing that is currently, I think, one of the main barriers for people to get psychedelic assisted therapy is the therapy component. Therapy is very expensive. This is what's the primary cause for, many thousands of dollars in costs, whereas the drugs are kind of cheap. So if microdosing works in isolation from therapy, then we just kind of created a whole new class of substances that could be so helpful for so many people. So, if microdosing is effective, we have discovered something very interesting and important. Now, this is when I talk about open science and the importance of doing science properly, because these are huge motivations and everyone wants it to work so badly. And this is something that I've encountered a lot in psychedelics in general. So, I want to quickly talk about how science ought to be done. So generally, the way it works is you come up with a hypothesis and then you design a study that would test that hypothesis. You collect the data and then you analyze it. You write the results up, you publish them, and that helps you write your next hypotheses. And so this is kind of a self-perpetuating cycle. However, something that's kind of rife in many disciplines, especially psychology and life sciences, is there's a million ways to get this wrong. And I'm not going to get too much into this. This is something I'm very passionate about, but this is not what y'all came here to hear me talk about. So I just want to say in a word, it's really, really important to do good science. It's quite rare in psychedelics. This is something I very strongly believe in. And I think that I do good science. And um, part of it is by doing open science, and I'm going to talk about that in a minute. But I'm also inviting people to say, hey, you know what? You could have done this better. Because I don't know everything. And a big part of doing good science is being open to feedback. So please feel free to reach out if you have comments. So, on top of that, as I said, open science. Open science is a good way to avoid many of the pitfalls that I showed in the previous slide, many of the ways to do questionable science. And there's kind of the three primary prongs here is the first is you pre-register your hypotheses. That means before you go and run a study, you make it concrete what it is that you're going to be looking at, and then you put that on a website. No one knows about it until you're ready to make it public. But then when the time comes for you to publish your results, you show the reviewers in the journal where you submit your paper, you say, hey, I planned on doing X and I did X. And where I didn't do X, I was explicit about how I didn't plan to do this, but then I had this cool thought, this cool idea, and I went with it, and we should consider that exploratory. So that's really important, and that's quite rare in psychedelics. And then the other two things are open materials, which means all of the measures that I use, all the measures that scientists use should be made publicly available so that other people can repeat their studies easily. So you don't need to reach out to me to figure out how I did things. Everything is available online, and you can just repeat what I did. Finally, open data, also very, very important. Most of the data that I'll present here today, except for the clinical trial, is available online for free. You don't need to talk to me to get it. And then you can, A, repeat my analyses, make sure that I didn't make mistakes because I'm human and I make mistakes all the time. So this is part of us being kind of accountable to each other. And the other part is if you're a junior researcher and you want to get some data and run some analyses that maybe stuff that's interesting and I didn't think of, go ahead, go for it. The data I collect, funded by taxpayer money, and the people who participate are just the community. So it only makes sense that this data belongs to the community as much as possible. Sometimes there's other considerations like anonymity, etc., but as much as possible, my data is open. So if you remember nothing else from this talk, the most important thing, remember about the importance of open science and try to believe people who practice open science more. Now that I've given you my little spiel, let's talk about some results from microdosing studies. The first study we did was almost 10 years ago. It was because there's virtually no research on microdosing at all. And we wanted to see whether we'd find anything using zero money and zero support because it was just, we were all basically graduate students. So we just wanted to see whether people who microdose on the internet will respond to our survey. And we had some hypotheses about it. So what we did was we created a survey, we pre-registered it, and then we posted it on a bunch of subreddits, on Facebook, on Twitter before it was X. And we just wanted to see who these people are, what they report, and then we also had some specific hypotheses. And where we had hypotheses, I will be explicit about it. So first of all, we had almost 1,400 participants, which was amazing. This is way more than we thought. Mostly white, mostly male, mostly heterosexual. This kind of fits with the population that frequents Reddit, or at least frequented at the time. It may have changed since. And on one hand, this is a confound because then it doesn't speak so much to other demographics. But on the other hand, if we're not trying to say, hey, we can infer to every single human from this. What I'm going to show you is probably stuff that we can infer to these kinds of humans. The next thing that we asked is we asked people where they are on their microdosing journey. We asked, so people could say they have either microdosed in the past, but no longer microdose, either, or they microdose now, or they intend to microdose in the future, or they haven't done it and don't intend to do it. That's kind of the control group. So what we had was 29% who are currently microdosing. We had 37% who were interested in microdosing, or sorry, that have microdosed in the past, and then 30% who have not yet microdosed but are interested in it. And this kind of gave us a bit of a pseudo timeline. We could compare between these groups. We also asked people how frequently they microdose. And most commonly, people said every 3 days. That's the Fadiman protocol. It's the most common one. I believe it's still the most common one. But then you see that there's a bit of a bimodal distribution. There's another significant bump at people who do it every week or so. And the way I interpret this is that, at least at the time, there were some people who were doing this almost medicinally in a very regimented way, whereas some people were doing it more as something they do once in a while, probably on the weekend. And I assume they would also take a larger dose because it was on the weekend. This is just my interpretation, and it's really based on nothing, but that's my opinion. So moving on to some quantitative findings where we had, these are all pre-registered hypotheses. So first of all, we hypothesized that people in the microdosing group would be lower on the personality trait called negative emotionality. In previous iterations of this scale, it was called neuroticism. And indeed, this is what we found. Not a huge difference, but a significant difference nonetheless, with people who microdosed had lower negative emotionality. It's kind of a desired thing. The more negative emotionality you have, the more likely you are to be depressed and have kind of a host of other negative mental health outcomes. We also hypothesized that on the same kind of personality measure, people in the microdosing group would be more open-minded. And that is indeed what we found. Again, not a huge difference. And you can see that there's a bit of a ceiling effect. Kind of everyone's very high on open-mindedness. So we found what we expected. Okay. We also hypothesized that people in the microdosing group would be lower on dysfunctional attitudes. These include stuff like if I fail partly, it's as bad as failing completely. It's a cognitive measure of tendency towards depression. So we hypothesized people in the microdosing group would be lower in this, and indeed they were lower in that as well. We also measured wisdom. Don't, yeah, I know. What is wisdom? How do you measure wisdom? I don't know, but there's a verified wisdom scale out there that has been published and has been used in multiple studies. I'm not going to use this scale again because I have deep issues with measuring wisdom. But nonetheless, we hypothesized that people in the microdosing group would be higher on wisdom, and lo and behold, they were higher on wisdom. So we have these four self-report things where everything is going exactly according to plan. People in the microdosing group are better at the good things and also lower on the bad things. The last thing we did, which was, I think, fairly revolutionary at the time, we also measured creativity in a way that used tasks. So we actually had people complete the unusual uses task, in which you are basically, we told people the name of a household object, and we asked them to come up with as many creative uses for this object as possible. And then we had judges that didn't know the group assignment rate these according to three dimensions, which are uncommon, clever, and remote. I'm not going to explain more about that now because we have a lot of ground to cover, but people in the microdosing group were higher on all three dimensions. And it's cool because this isn't just self-report. This isn't just, oh, I'm microdosing, so I should be higher on the good things. These are just people doing stuff to the best of their ability. And it was pretty cool to find this. Um, Now, moving on to some qualitative findings, which were not pre-registered. These are, and we're just like, we wanted to ask people, what are the three main benefits and what are the three main drawbacks that you've experienced from microdosing? And then we used basically qualitative methods. We used um, grounded theory to come up with, to bin what people said into categories. And so, in terms of benefits, we had the most common benefit by a wide margin was improved mood, followed by improved focus, and then creativity. In terms of the drawbacks, by a wide margin, illegality, which is not about microdosing, it's about public policy, it's about legislation. And that was followed by physiological discomfort, stuff like feeling hot or cold, trouble sleeping, sweaty palms, GI discomfort, nothing too severe. And then the next most common drawback, we binned it as other because we couldn't really put a through line in it. And it was stuff to do with, oh, I wish there was more research, or I wish I knew how this interacts with my medication. But again, nothing too serious. Now, the perceptive viewer may be looking at these two pies and saying, hold a minute, I'm seeing some things that are reflected in both of these. And I agree, that's very weird. How can microdosing increase anxiety but also reduce anxiety? How come it increases focus but also impairs focus? That's pretty weird. Um, could be explained a few different ways. I think the most realistic and likely reason is that it's all placebo and people just kind of are all over the place. Another likely reason is that people are using microdoses in different sets and settings. So it's probably a lot easier to improve your focus when you're microdosing if you're painting or if you're on a walk or if you're listening to music. Whereas if you're at the office under fluorescent lights for 8 hours, yeah, it's going to interfere with your focus. So these are just two of the possible reasons. If you read the paper where we published this, you can learn more. Now, there's this, we didn't really have hypotheses here. We didn't pre-register them rather. We just asked people if there have been changes in their behavior on a variety of measures, just if there's been an improvement or not. So it's a little bit confusing, but triangle pointing up is improvement and triangle pointing down, or sorry, basically triangle pointing up is, yeah, is more, no, it's an improvement on the scale, and a triangle going down is, I guess, also an improvement. But like what you see, like 70% anxiety is, it means that people's anxiety improved by a lot. Or meditation, also people meditated more, but you can see that mood is again an outlier with like almost everyone reporting an improvement in mood. So based on this, I'm thinking, okay, it seems like microdosing is pretty amazing, right? Well, let's just recap what we found. So it's good for the personality stuff, good for wisdom, good for dysfunctional attitudes, and good for creativity. Great. Now we have some preliminary results, and you see the link at the top right, or sorry, bottom right. You can read more about our pre-registration and access our data there. Now, the next thing we did was to try and replicate our results because just because we found something once doesn't mean so much. So we did that as part of the global drug survey, but because there were so many participants, it's a fairly long survey. We couldn't test everything out. So we looked at, first of all, what people used. So mostly LSD, some magic mushrooms. We also asked people why they microdose. And we added something here that we didn't have before, that just curious. So a small plurality was microdosing because they wanted to improve mood, but the second most common, and not by a lot, was they were just curious to see what it does. And then you had kind of the other usual suspects, creativity, productivity, stuff like that. We found a similar trend for LSD, mostly mood, but then just curious. And so there's something maybe there, or at least at the time, this was in 2020, there was maybe something there about people getting curious. Now, I want to talk a little bit about what others have found. Um, so, in other surveys, people found either not much or some positive things like Polito and Stevenson found increased connectedness, creativity, happiness, productivity. Others you see have found kind of improved mood, some improvements in creativity, again, replicating our findings. So this is encouraging. However, the next thing is that I looked at is what about the randomized control trials? And in these lab studies where, people didn't know if they were microdosing or not, kind of not really so many findings, if anything at all. Um, but if we want to still believe that microdosing works, and we want to find at least the glass half full here, we can say, well, microdosing does not seem to have any significant acute negative effects, and it might be effective in surveys, but not in RCTs. So that was roughly the landscape of the research when I started working on my clinical trial several years ago. Now, I want to change gears and tell you a little bit about this trial. I want to tell you how we did things, and I want to tell you what we found. So we randomized participants. We ultimately had more than 30. I think we had 39 participants. And people were randomized either into placebo first or psilocybin first. And then they would come in once a week for 4 weeks to receive 2 milligrams of psilocybin. The the psilocybin content in mushrooms varies widely, but this is something that we said, this might be roughly comparable to 200 milligrams of dry mushrooms, which is what people use in the wild, more or less. And so for the first 4 weeks, participants don't know what they're getting. We don't know what they're getting. And they're doing a bunch of tests. We're asking them a bunch of questions. They stay in the clinic the whole day. And they only come in once a week. But we also send them a questionnaire 3 days after each dose. So on the Saturday, they're in the clinic. And then on Tuesday, they respond to a quick survey checking in with their mood. Because the primary thing we were looking at was mood. I don't remember if I have this later, but the population we were looking at was major depressive disorder. After these first 4 weeks, where people come in once a week and get either placebo or psilocybin, we switch to an open label phase. During this phase, everyone gets psilocybin for 4 additional weeks, and everyone knows that they're getting psilocybin for those additional 4 weeks. Um, we did this because we wanted to see A, whether how much expectancy plays into people's reports. We did this because we wanted to get a baseline for everyone. And then this way we're able to compare people to their own baselines. Um, and we also wanted, the kind of the gold standard is to compare placebo to the experimental group, but we also wanted everyone, we were like, this might work. This might actually help people. So we wanted everyone to have access to this medicine. And so through this design, everyone gets access, which I think is really important. And then we also followed up with them for 4 weeks after the end of the trial. Again, just kind of seeing what their mood is like. So I want to start telling you, I'll tell you what we found, but I want to start by first telling you about the demographics. So uh, normally, a major issue with a lot of psychedelic research is that most participants look like me. And I mean, it's good to know if it works for people that look like me, but I think it's also really important to see if it works for human and not just for white guys. So I'm happy that we had more diversity in our sample than what we've seen in most other studies. Still a plurality of white, but a good amount of other people. Also, not just young people. I feel pretty good about this too. Um, so we had people, I think our youngest participant was maybe in their late 20s, and our oldest participants the cutoff was 65. We had a couple of people that were very close to the cutoff. So I'm glad that we were able to include them as well. And they were not all guys, which is again pretty good. I'm happy that we had something that's pretty close to 50% male. I think we had either one or two trans people, which is again, I think they're so underrepresented in these studies. So it's nice to have representation. The first thing I want to describe from the results are the adverse events. So what bad things happened when we gave people microdoses of psilocybin? Well, nothing huge. People described confusion, nausea, headaches, some way more sleepiness than what I was expecting. Some people needed serious naps. But everything was transient. Everything was mild. We were able to release people home at the end of the day without fail. And yeah, I think there were adverse events, but nothing serious, and it all went away quickly. So now let me tell you about some of the quantitative results. And we're specifically, again, focusing on stuff to do with depression. That is the main reason we ran this trial. So the first measure that I want to show you is the PHQ, the Patient Health Questionnaire. It's a very standard measure of depression. And you see that there's no separation over time. Everyone got way, way better. I don't remember if it's for this particular measure, but for for all these measures of depression, we had a Cohen's d of something like between 1.8 and 2, which is a huge, huge, huge effect size. So you can see that people started presumably mild to moderately depressed, and by the end of the trial, they were no longer technically depressed based on this measure. So based on this, I'm saying it looks like participating in a trial is really good for you. Moving on to another measure of depression, the QIDS, Quick Inventory of Depressive Symptoms, basically the same trend. Everyone gets way better over time, and there's no separation between the groups. We also use the SCID, which is it's a structured clinical interview that checks all of the DSM-5 criteria for depression. And so this we didn't do every study day. We only did this at baseline and then halfway through, so just before people crossed over to the open label, and then at the end of the study. And here again, there was no separation, and you can see that basically everyone got better. To give you an idea of what each of these numbers means, to have a diagnosis of depression, you need to satisfy 4 out of 9 criteria. So if people went down by 3 to 4, that's basically no one would be depressed, which is again pretty incredible, huge effect size. Now, the next thing I want to present um, is a little bit more complicated. It doesn't directly have to do with depression. It's the inclusion of self in others. So what this measure does is you give them different domains in life, like friendships or family or work relationships, and you ask them to rate which of these is true for them in that relationship, going from the top left, which is no overlap between me and the other person in this relationship, and the bottom right, which is pretty much complete overlap between me and the other person in this relationship. This is a measure of connectedness, among other things. And I've argued for a while that at least part of the mechanism through which psychedelics improve mood is through an increased sense of connectedness, which is why we wanted to measure it here. We thought people will get better, and at least one mediating construct will be the iOS. And this is what we found. Now, technically, um, by the end of the study, by the end of the 8 weeks, people in the psilocybin first group were significantly higher on this than the people who started in placebo, meaning they had more inclusion of self in others. But you see, based on the design, you'd expect there to be something different going on. You'd expect the group that received the placebo first, the red line, you'd expect them to start improving after session 4, which is when they start receiving psilocybin. But that is not what happened. So, I mean, I'm like sharing everything I know. These are the results we got, but also my read of this is that this is not a real effect. It might be, but I think it is not. And then the other thing that I did want to say that there is room for some optimism about is the dysfunctional attitudes scale. You might remember it from the survey that we ran. Here we were really able to replicate, we used the exact same scale. And you can see that until the middle of the study, there's no separation and really no one improves. But after the midpoint, that's when people in the psilocybin group start improving way more. There is separation here. This is a significant difference. So I'm not sure how to interpret this. One way to think about it is, again, this is an artifact. It means nothing. And yeah, there's no real difference. Another way to think about this is that it might be that our study was too short. It might be that it takes a while for these effects to kick in, but I don't know. So this is something to keep in mind. Now, we also, uh, I think one of the more revolutionary things we did here is we checked about sobriety. Some other microdosing studies check masking, but we also really cared about sobriety. So let's start with sobriety because that's what's first. So people did many, many of these tests. They did this at least once every time they came to the lab, sometimes more than once. And these are kind of this is the roadside battery that you get if you get pulled over. So it's fairly standard, which is good because then this is stuff we can bring to legislators and say, look, people who microdose are legally sober. I'll just summarize this table. 3 people failed sobriety tests, and out of these 3 people, one was in the placebo group. So, and this is 3 out of hundreds. So to me, I'm reading this as people were by and large sober. This is not the be all end all definitive test, but this is at least a very encouraging indicator that While our dose maybe wasn't super effective for the things that we were interested in, it was also low enough for people to be able to do most things, presumably. Um, Now, the next thing I want to talk about is whether participants broke blind. I think the psilocybin group is more informative here, because you see that 63% of people correctly guessed their condition when they were taking psilocybin. That is more than chance. That's significantly more than chance. We ran an analysis for this. So this tells us that, yeah, even though this dose was so low that people were technically sober, it was high enough that they knew that they were on something. So to summarize this, microdosing may affect feelings of belonging. It may affect dysfunctional attitudes, but for everything else, it had no effect above and beyond placebo. We know that 2 milligrams, which was our dose, was well tolerated. Most adverse events were mild and transient. And we know that basically everyone passed sobriety, but that also people in the experimental group were really good at guessing their assignment. So to me, these findings taken together suggest that we need a new definition for microdosing. Because as I said, some have used subperceptual, I've used subhallucinogenic, others have used low dose. And I think that a more accurate definition would be non-impairing, because people know that they've taken something. And it might have an effect, we're not sure yet, but it might have an effect on some measures of well-being. Excuse me, but yeah, they knew that they were on something. So this is the new definition that I'm suggesting, and I'd be happy to hear what folks think about that. Now, I want to talk quickly about some of the strengths and weaknesses of this trial. Um, like I said, one strength is it's way more representative of the real human population than many other psychedelic trials. And the other is we were very, very intense about keeping it strict and consistent, or said differently in scientific terms, reliability and validity were high. We were consistent in the way we administered scales. All scales were validated. People were in consistent set and settings. So it's not like some people were at the lab, some people were at home. We really kept things the way they're supposed to be. And so whatever we found, we should be relatively confident about. Now, in contrast, some of the weaknesses, one is I wish I had more money. I wish I had more participants. But unfortunately, I only had as much money as I did, and we could only run as many participants as we did. So future research, I would love for that to be me, but if it's not me, if it's any of you, please, more participants are needed because it might be that the effect sizes from microdosing are too small to have been detected. Then the other thing is people don't microdose in isolation at a lab and just do tests for 6 hours a day. That may have completely gotten like gotten in the way of whatever positive effects people may have gotten from microdosing. So future research, I think, we should continue. I think there's kind of two sides to this. One side is what we were doing, which is reliability and validity, internal validity. And the other side is the ecologically valid side. We need to track what people are doing in reality, in the wild. And maybe there's better ways to administer microdoses. Maybe doses should be different. Maybe the isolation is bad. Maybe people shouldn't be doing so many tests all day. But these are just some of the thoughts. Now, I want to thank some of my collaborators, and then I'm realizing that we still have some time. But maybe let me thank collaborators. We can do some questions, and then if there's time, I will show more slides. So I want to thank Dr. Adam Blackman, who was the PI for this study. He's a psychiatrist, and he was so helpful. Dr. Norman Farb from the University of Toronto, who was also invaluably supportive throughout. David Shore, who was my PhD supervisor. Shahana Sitampalam, who was the study clinical coordinator. Thomas Anderson, my colleague that I started this research with, and Erica Lee and Omer Said, who are have been so helpful throughout running the trial. And I am writing multiple papers with them now. They're both graduate students and they're brilliant, and I highly recommend following their work because I think they're both going to get far. So let's pause here. You can check out our website. You can check out our where we are on the Open Science Framework. You can email me. But yeah, we can pause for questions. I take it no questions then. Oh, hi, Karen.
I'll ask a question. Hello. Thank you so much for your presentation. I followed some of your research. It's great. Um,
Thank you.
you know how like what is a microdose can vary by person in terms of their sensitivity levels? And it makes me wonder, how do you design a study that like what is the apples to apples to comparison? Is it the numeric dose or is it for that individual what is a microdose or the word you said you're inviting us to consider using? I forget now.
It's
Not altered?
sub-impairing.
No,
Sub-impairing.
sub-impairing. Okay, so, sub-impairing levels for me might be, a heck of a lot lower than somebody who's less sensitive, for example. So, yeah, I'm sure you've probably talked about this. Like, I'm curious what your team thinks about that.
Yeah, it's a great question. And it's tricky because we don't know. I mean, yeah, I think this is kind of the holy grail of psychedelic research. Like as far as I'm concerned, if you yeah, if I had $100 million, this is what I would pursue. I would figure out what is the response curve for humans and how to predict it. But it would be extremely costly. I think it's probably not genetic because there were a couple of companies that were trying to figure that out a few years ago, and they both disappeared. Even though it makes sense because there's a particular, I think there's two particular alleles that code for the 5-HT2A receptor. So it would make sense that it would be genetic, but I haven't heard anything about that. In my mind, but this is my bias, it's likely to be about your psychology. So it's likely to be about personality differences. But we don't know. Like I can tell you, let me maybe offer two more pieces of information. One is in our sample, some people had, I would say, mini journeys. Some people were like crying and kind of had memories come up and yeah, and some people were absolutely consistently unable to correctly guess their condition. So that's one thing to consider, which I guess supports what you were saying. And the other is, oh, sorry, one more thing to say about that. I have no idea if those people who had many journeys were in the experimental or placebo condition. So also we need to remember that placebo response is unbelievably strong. The other thing is there's another group from New Zealand who recently they just posted the results. They haven't published anything yet, but they ran microdosing trial with LSD that was roughly twice our size. But the way they did it is they let participants titrate their own doses. I think there's something to be gleaned from that. And I'm very curious for when they publish the results. But I also like, it depends on the epistemic approach that you bring to this research. And what we were trying to do here is basically like pharmacological research. We wanted to see if drug causes change in behavior. And maybe that is incorrect. Maybe that is insufficiently nuanced to assess the impact of microdosing. And so maybe what we'll learn from the New Zealand group will be way better than what we learned here. So stay tuned. Any
I'm
other
going to jump
questions?
in. Yeah,
Yeah.
totally. Thank you for this. This is fascinating. I'm as a public health epidemiologist, I'm a total junkie for this quantitative stuff. So thank you. And the open science, as well as the open label studies. So don't stop, do more. Send money to Rotem, please. A couple
Thank
of
you.
questions. So firstly, in either the first or the second study, were your participants diagnosed with depression, or and I seem to understand that the second one potentially, but the first one where you recruited from sort of like Reddit and various other forums, there was not necessarily a diagnosis. Is that correct?
Yes.
Okay. But the
Sorry, do you
second
want me to
study,
add more, or is that you just want the clarification?
yeah, no. In fact, if you could add more, that'd be great because I've got a whole host of questions here. Go on.
Oh, sure. So I just want to say at the time I was just interested in seeing whether there was hype around microdosing. So in 2016 we ran the survey, and then we found in kind of healthy normals, and then the next we wanted to run a clinical trial on healthy normals, and Health Canada said, "Are you crazy? These are very dangerous drugs, and this dose is very dangerous." So to justify the cost, or rather the risk benefit analysis, you need to have a clinical population. So we switched to people with major depressive disorder.
Okay, gotcha. So the second series of results, that makes a ton of sense. Um, so in the second study, in fact, in either study, did you ask if people were also like receiving therapy at the same time? And as in
Yeah,
like,
great question. Yeah, so
go.
I I feel like, yeah. So I'm having second thoughts about the way I structured this talk. But yes, we had many things that we asked participants to not do in our clinical trial. So people could not be in therapy. We didn't include people who were, so some people said, I'll quit therapy. And we're like, No, we don't know that this does anything, and it would be unethical. Therapy is good and we know that, so don't. People could not start diets. They could not start supplements. They could not start exercise. They could not change their caffeine intake. We were such sticklers. We thought about as many confounding variables as possible. We wouldn't let people work night shifts because we're like, I don't want you to show up tired. I want you to smoke as much as you normally smoke. I want you to have as much coffee as you normally have. Like, none of this stuff.
Okay, cool. So then, so you're essentially your control conditions or your control population and your study population before you switched over, they were effectively the same.
Yes.
No major changes. Perfect. Connectedness scale. Sorry if I'm sorry, and please don't have any regrets for how you presented this. Like this is like a totally awesome presentation. I'm so delighted that we get any
Great.
FaceTime with you here.
Thank you.
Connectedness.
I'm here for the engagement. I was like losing my mind talking just to my screen, so I'm so happy you're here. Yeah.
Oh, that's great. Well, I was losing my mind because I was thinking this is awesome. I'm a junkie for this. Perfect. Um, Connectedness scale. So the most recent chat that we had was with Leor Roseman, who actually used a connectedness scale out of Rosalind Watts's lab. How does the scale that you use compare to that? Is it similar? Is it different? What's it like? And is it a scale that you only use with people who are depressed, or could you use it with, say, like somebody who's interested in like population health as an example?
Right. It's a good question. I think there's at least two primary approaches to instruments that we use in psychedelic research. Some people are saying psychedelic experiences are so unique and profound that we need psychedelic specific instruments to really plumb their depths. And then there's some people that are saying the opposite. Psychedelic experiences are important, but not unique. They are in the spectrum of human experience, and other instruments that we have may be sensitive enough to pick up on what they do. Now, this is important for all kinds of reasons, but for me, the reason this is important is that what I want is for psychedelics to be mainstream. And I want it to be, I want for us to build a solid foundation. I feel like that's kind of like I lost the race on that. But I think that if we want to have a strong foundation, we should be using well verified, validated instruments that are psychometrically sound and are used by the wider scientific community. That is our way to communicate that what we're doing is legitimate and that we can compare. We can compare the effects of a psychedelic intervention to the effect of mindfulness meditation and to the effect of therapy and the effect of positive affect induction and kind of other interventions that we have out there. And so I much prefer to use instruments that are already well established. This is not to denigrate the connectedness scale. I think it's great. I think it measures things that other like it filled a hole. There was a lacuna there, and we need this measure. And at the same time, I think that, like the iOS is fairly established. It's used a lot in like in the context of cyberball, if you're familiar with that. Like basically when people are made to feel excluded or or in prisoner's dilemma situations, because we want to see how would this affect people's behavior in reality. So if I could run this study again, I'm not sure that I would use this measure again, because the other thing is that this study was like, I was done designing it and it was approved by Health Canada in 2021. It just took a million years to get through all the red tape and all the other kind of logistical issues that I had. And by that point, yeah, there have been improvements in the literature, but I didn't want to annoy Health Canada. So I just wanted to keep going and like did do what I did.
Awesome. Okay. And then thank you for this. Actually, I'm not going to say annoy Health Canada because this is being recorded, but um, with the placebo and the expectancy effect, actually, in your open label study, do you think if you'd had a third arm that didn't receive any, you might have seen, yeah, go on, you see where this question's going. So if you had a placebo exclusive piece, that I don't know, I mean, that you offer, you know, for whatever ethical reasons you offer them at the end, but you don't include them in your study. Do you think you'd have seen a similar expectancy kind of effect in like a group that ran out the full interval without any microdose?
Yes. Yes, and I have a colleague who is currently looking at running something like that out of the University of Toronto. And while I find it absolutely fascinating scientifically, I think there might be an ethical problem with this
Mhm.
because
I'm with you on
at the
that.
end, sorry?
I'm with you on that.
Yeah, because
The ethical part.
like ethics boards generally are apprehensive about using deception. And if you use deception, you have at the end to say, "Hey, I deceived you." And these people are at risk, and we don't want whatever gains they got that they could go get like crash into a worse situation than they were before. So yeah, from the perspective of kind of balancing harm and discovery, I think it wouldn't be worth it, sadly.
Okay. Yeah, I agree with you from a scientific curiosity perspective. It's just when you look at your graph and you see your placebo group improving to a certain point and then separating, it's just more like it begs the question, actually. And then I guess the final question, and this is legit going to be my final question for now, is did you consider doing like a low and a high dose? So microdose and a high dose.
Yeah,
And
definitely.
seeing
But
what
I think so it's funny. When I designed the study, I was just and I was like into experimental psychology. And in the time since, I've become a clinician.
okay.
And so I think that the dose isn't what it's about. And I think everyone has had, or let me rephrase. I think most people that are part of this conversation right now know of people that have had even large dose, very meaningful experiences that do not necessarily lead to any significant clinical changes. I think that therapy is key. I think that this can be an adjunct to therapy, but I don't really believe in psychedelics as the thing itself, as the teacher. And yeah, so by the same token, yeah, right now I'm looking at running a study that would be maybe like 2 milligrams and 4 milligrams, but the key is adding therapy. I think with therapy, like maybe the thing to do. And in a way, this kind of goes around the concern about placebo because if what we learned from the study that I presented here today is that 2 milligrams is basically placebo, then we can give that to people with therapy. And then we compare essentially therapy with placebo and therapy with 4 milligrams. And then let's see if there's separation there. I think that's a more interesting question.
Mhm. Cool. This is
Awesome.
exciting. I'll
Thanks,
be
Anna.
yeah, no, this will be really exciting to see. Yeah,
Yeah,
these are exciting times. So yeah, don't stop.
right on. Thanks. I'm so happy you asked a bunch of questions. Yeah, this is great. Thanks. Cool. More questions?
Yeah, I was just gonna on the last part you said about treating microdoses as placebos. I was actually thinking about that as you guys were talking. And do you know of any studies that have done that or are thinking of doing that?
Definitely.
So there is
Yeah.
some results out there?
Many, well, many,
Okay.
a handful. But just now that I'm thinking about, how difficult and complicated it is to run any psychedelic trial, it feels like many. There's a handful. I think the Compass studies used 1 milligram psilocybin as a placebo.
Okay, that's interesting. And that was in Ontario, no?
I think they had many, many sites.
Oh, okay. Okay, that's interesting. I'll look into that.
Yeah,
Thank you.
yeah, no worries.
Can I have one more question? Okay, so one of the coolest papers I read this year was actually about insights. In fact, I want to say it was David Gadden, Joshua Kuhl's the sort of the first author on it, and it's referring essentially to insights as opposed to mystical experiences and so forth. What are your thoughts on the use of terms like mystical experiences in this particular end of things, and how it was kind of groundbreaking to see a term like that used in a scientific publication at the time, and just in terms of like how you mentioned using regular psychometrics and not psychedelic specific ones. So what are your thoughts on terms like insights or mystical experiences?
Mystical experience is easier for me to address because I
Mm.
think it's fine. I think kind of it's a scientific theory. It's falsifiable, it's coherent, it's clear, and like any other theory, we're gonna have to continue to improve it, and maybe at some point we'll have to throw it out completely and come up with something better. But I think that mystical experiences are fine. I understand that. I guess, yeah, maybe it's because I'm steeped in this so much, but I'm like, yeah, this sounds fine to me. But when you said, I understand how this sounds like it's not mainstream, but I think that's fine. Insight, I think, is trickier because it's been used a bunch of times over the last, say, 100 years to describe a bunch of different things. Um, and so it's way more slippery, and
Mm.
I am more wary of that.
Oh, cool. Interesting. I would have thought the other way around. That's great. Thanks for that.
Well, yeah, because I'm thinking so Vipassana is insight. That is just the translation. And insight also shows up in this, it's a type of creativity, right? Insight where like some creativity is incremental when you kind of slowly come up with a solution, and or you can have an aha moment. That's also insight. So these are just two right off the bat that I'm like, what does that mean exactly? It's one of those things. It's like you know it when you feel it, but where's the scientific theory there?
Mhm. Yeah, in terms of defining it. Okay, cool. I'll keep an eye over. I will. But thank you for that actually, because that was probably one of the like eye-opening papers I've read in the recent past. So I will read it again with this. Yeah, in this lens. Thanks.
Sure, I should say I have not read this paper, so maybe I should read it too.
Oh, I'll put it in the chat so you have it.
Great. Thank you. Cool. Okay, so do people want to see a couple more slides? Great. So whatever you think so far about the results from this trial, your mind might change, or I guess let's see. So there's many more measures that we have from this trial that some of them we haven't even analyzed yet. Like we looked at creativity again using multiple different measures of creativity. And we looked at sustained attention using two different measures of sustained attention. We haven't analyzed that yet, but there's a few other things that we have analyzed, and I want to share with you. So the first is reading the mind and the eyes. This is a measure, like just what you see. You are given just someone's eyes, like a picture of someone's eyes, not the whole thing. And you need to guess what are they feeling. And we use this because there have been some reports about kind of how microdosing makes you more social or better in social situations. Um, but the issue is that this is a measure that was developed by um, an autism researcher. It's for people with autism, and so everyone was great at it. So there's no separation because ceiling effect. So we didn't find any difference in the reading of the mind and the eyes. Now, going back to personality, you might remember these guys from before, negative emotionality and open-mindedness. No difference really between the two. Um, there might be a little bit, you see an interaction. The um, negative emotionality, the lines cross over, but the difference, if any, is minuscule. So I think that there's no difference on these either. We also asked about mindfulness, and there is no difference there. Um, yeah, just everyone improved slightly in mindfulness. And then we also asked about interoceptive awareness. This is based on the theory that if you're more mindful of your body, then that is related to kind of emotional regulation. My colleague that I mentioned before, Norman Farb, recently wrote a book with Zindel Siegel about this. It's pretty interesting. Um, I don't remember what it's called, but I can share it if people are interested. Anyway, some examples of this of interoceptive awareness questionnaire is stuff like I notice when I'm uncomfortable in my body. I notice where in my body I am comfortable. Um, Stuff like that. Again, because we assume that if you're better at noticing your body, your affect regulation will be better. And the answer is not in this case, or rather, in this case, people's um, interoceptive awareness did not change at all. Oh, I thought I had another one. Well, I can tell you that we also asked people about pain, and there is no difference in chronic pain or the way pain affected people's lives. But in that case, too, people didn't really have terrible pain. So um, maybe we hit kind of a floor effect there. All right, so these are all the slides I have for you today. I'm going to stop sharing my screen. One last opportunity to ask questions, I guess. Oh,
Sure.
right, better in every sense. That's right. Thank you.
I have another question.
Yeah.
What is your theory or even your hunch on the being in a trial effect? Like, why is it good to participate in a trial?
We've been talking about it a lot internally. Yeah, again, I love these questions are so good. Um, I think there's a few different things operating here. My colleague, Ada Blackman, that I mentioned before, was calling it the milieu effect. It's because, people show up and we make them feel good and we make them feel valuable, and we make them feel like they're contributing to science and they're at the forefront and they're doing what they can to resolve their depression. And we're just kind of nice to them. We put quite a bit of effort into trying to balance that, being professional, but also warm. Um, but I think it's primarily that along with the pollen effect. Have you guys talked about it, heard about it? Yeah, I think people, oh, okay. So it's, my colleague Tassine Irani coined this, I think, like 5 years ago. It was after How to Change Your Mind. And it's basically the people have such crazy expectancy now that, yeah, whenever they come in touch with psychedelics, the expectancy plays out in very strong placebo responses. So I think it's kind of a mix of all of these things. But yeah, I can give you an example. There was one participant who was up until the trial was unable to leave their apartment for months. They were fairly severely depressed. And then they came week after week and just got so much better. But another way to think about this is just behavioral activation. It's kind of a basic tool in CBT. Does that make
Well,
sense?
just a little follow-up. I mean, because you said earlier you think that it's the therapy part. And I wonder, like my own personal hunches kind of relate to like use the word milieu. I think about just like purpose, fun, activities, like the
Mhm.
general things that make the human animal feel vital. And that would be a lot harder to get money for a clinical trial than therapy. But I suspect that, there's just something about meeting some of those basic social and purpose needs that the trial is probably offering in some way. And
Yeah,
6 hours of attention, that's a lot of attention to
yeah,
receive.
for sure. But I think, yeah, I think, you know, placebo is effective even when you know it's placebo. So I would love to get some money to just bring people into the lab, tell them that they're getting placebo, have them fill out some questionnaires and see their depression scores drop. That would be amazing. So, yeah, what I've been telling myself is that, running this trial has shaved years off my life, and I do not recommend it to anyone, certainly not if you're a graduate student. But one of the things that I've been telling myself is that, at least these 39 people, even if the microdosing did nothing, the trial itself did some good. So feeling good about that.
So were your participants in contact with each other when they came to the clinic, or were
So
they
we didn't.
isolated?
That's a good question. There's so many kind of points of failure to this very rigid design. So we didn't tell them that they can't talk to each other, but we also put them in separate rooms. And I'm fairly confident that no one made friends, which I'm kind of sad to say, but also I think it's for the best.
Yeah, no, 100%. I don't know if you know Rachel Finetry at McMaster. Her research is on music therapy.
Hmm.
And she had a similar finding where she did a study comparing music therapy to normal therapy, and the results weren't that different. So the music wasn't the mediating factor, right?
Hmm.
And when I asked about that, she said that maybe the value of the music therapy is to just encourage people to stay in the trial and keep coming to their sessions.
Definitely.
Uh,
Yeah, that
yeah.
that checks out. I have a friend and colleague, Arla Good. She's at
Mhm.
TMU, and she studies, yeah, communal singing. And they're getting such beautiful effects. And I'm like, of course they are. Singing together is awesome. And part of her bigger project is what's referred to as social prescribing, where by now, this should be considered an evidence-based intervention. So really, people like physicians should be prescribing this because it works. And unfortunately, it's not happening yet. But yeah, I fully agree. And I think anyone who says that they have the one and only answer is probably wrong. And I think we just have, a bunch of different ways of tapping into what's good for humans.
That's well said.
Hmm.
And are you hoping to do more microdosing studies in the future, or are you just shifting gears now?
I think that's a good question because I think if you talk to other people who've studied microdosing, the normal trajectory is you start excited about it, you find null results, and then you move on to other things. And I think that if I could, on a dime, turn around my career now, I would want to focus on the placebo response because I think it's way more interesting. But in reality, I have a bunch of inertia, and I think the other question that I think is very interesting, and I hope to answer, is we know that large doses do something, and we don't know what the minimal viable dose is. So it's probably not 2 milligrams, but maybe it's four, maybe it's six. Maybe it's true that you need a mystical experience, but can you have a smaller scale mystical experience? So I think finding the kind of the lower bound for what is an effective dose of a psychedelic is still a worthwhile pursuit.
Following on that, do you think that the regime, like, so either, I mean, you did psilocybin, you could have done, you know, LSD. There's a few others you could have potentially done. Do you think the regime, like, I think of the Stamets stack, like 4 days on, 3 days off, like as a different, um, a different schedule? Do you think that would that be something worth pursuing, or are you like really people dabble in microdosing, or they don't dabble, they spend like, as you said, years of your life on this thing and then sort of move on to something else. And so would you like play with different schedules, different compounds?
Yeah, I think that the compound is less the issue here. But if I were to critique my own study, I think the fiercest criticism I would have is about the once a week is crazy. Who does once a week? No one does once a week. And I'm like, I can show that, yeah, hundreds of people, at least in whatever 2017, 2016, were doing it once a week. But the most common protocol is the Fadiman protocol, and the second most common one is the Stamets one.
Hmm.
So I think doing it twice a week is the way I would do it. Maybe 2 and 4 milligrams and adding therapy.
Oh, and adding therapy too.
Yeah, I don't believe that the drug itself is going to fix anyone. And also from the perspective of kind of social good, I I think I want people to get optimal results.
Hmm. Do you think it also depends? Like I think in one of the studies coming out of McGill where they're, the two arms, one is actually psychedelics and then the other is ECT for depression. Like these are severe, people with severe depression. Is it your potential patient population as well? Like would you, I mean, I can't imagine that you would go into sort of somebody with severe depression and treat them with a microdose as an example. Do you think that we're not classifying or we're not teasing out who some of the patient populations are in some of the studies, in terms of are we mixing apples and oranges and expecting a similar outcome or hoping for different outcomes?
Yes, I think so. Well, I think about how, you have different disorders have different etiologies. And what the thing that caused PTSD is not what causes depression, although sometimes PTSD will cause depression.
Hmm.
This and yeah, I don't know, humans are complicated. And the more I think about this from the perspective of a therapist, I'm like, no, we need to tailor stuff for people because different people are different and they have different presentations. But from the perspective of, someone who's trying to do pharmaceutical research and kind of representing the healthcare system, we need to find guidelines for what fits whom and when, even if they're not perfect, because at least they're fast and cost effective. So again, give me $100 million and I'll figure that out.
And is while you're waiting for the $100 million, like would you suggest that people microdose as an example until while they're waiting to get into one of your trials?
Right.
It's
So,
not assuming that that doesn't exclude them from actually being able to participate.
so I think another thing that, sorry, yeah, another thing that we had is people, our participants had to be psychedelics naive at least for 6 months, because I found that, or I guess we found that to be another confound. Um,
Hmm.
I can't recommend that people microdose. I would never suggest that anyone use illegal drugs. If you must microdose, I would strongly recommend taking breaks because it is possible that psychedelics are cardiotoxic. So take breaks, let your heart heal. Psilocybin is theoretically more likely to be cardiotoxic than LSD. So LSD is better in that sense. But yeah, take breaks for a month or two at a time. And if you do want to microdose, you can always email me and yeah, I can suggest some harm reduction approaches.
Hmm. Did you have cardiotoxic effects in any of your studies? Did you look for them?
No,
Did you find
there's no empirical evidence for this. There's one study on rats from 2006,
them?
where they gave them huge amounts of psilocybin every day, and guess what? That was bad for their hearts. Um, but yeah,
But great for their brains.
yeah, for everything. Um, but there's the reason I say there's theoretical reason is because the binding profile of these substances, especially psilocybin, also binds to 5-HT2B, and that is what fen was binding to. Which anyway, there was a drug, an antidepressant that was also it was cardiotoxic. It was very dangerous. It was removed from the shelves. So there's no evidence for this yet, and I think that would be a fairly low-hanging fruit if an ambitious graduate student wants to connect with a cardiologist and just kind of just post a bunch and say, hey, if you've been microdosing for at least a year, come get an echocardiogram. You do that
Hmm.
for a few dozen people. Compare that to the incidence of in the general population, and you got yourself a high impact paper.
A potential source of funding.
It would be fairly inexpensive. Like if participants
Yeah.
volunteer, the cardiologist volunteers, it's going to be a few $1,000s.
Hmm.
Cool. Any other thoughts, comments,
Well,
questions?
since you're inviting us to consider ideas, why don't you hook up with Corey Harris at U Ottawa, who did a postdoc on placebo studies, and he's super interested in that kind of stuff. That then you can have your dream of doing a placebo trial.
Sure. Thank you. Yeah, I'm
Mhm.
also I'm in touch. If you don't know Jay Olson, I also recommend following his work. He's currently trying to perfect the placebo machine. He's at U of T. Yeah, also a cool guy. But so you said Corey. Who?
Harris. He's an ethnobotanist.
Thank you.
He's on sabbatical this year, so maybe he's got free time.
Neat.
I've also seen some people microdosing with other substances involved. I've seen microdoses that have been packaged, advertised, that they come with melatonin,
Hmm.
and you're supposed to sleep with it. And I've seen a bunch of other things like I don't know if I'm saying it right, but the lion's mane maybe because it's another mushroom, I think.
Hmm.
Did you ever think of including those questions in the Reddit study, or were there any cases where you saw anybody saying that they do that?
Yeah, so Paul Stamets has the Stamets what's it called?
Stack.
There you go. Thank you.
Mhm.
And they tested it out empirically and they found nothing. So that's all I know about that.
Okay. Yeah, that's interesting. But mixing it with melatonin has always been a quite a question for me because I don't I don't know if anybody can sleep on even a low dose of psilocybin. I mean, I
Yeah,
get you get sleepy, but
I was
um,
consulting to a company a few years ago that wanted to
mm,
promote that.
mm,
I think they had a name for this protocol, the nightcap protocol, where people take it before going to sleep. And I was like, guys, this is crazy. You're just gonna have a bunch of people with insomnia. This makes no sense. But they insisted that this is a thing that people do in the wild, and I believe that, but I haven't really, I don't know anything about it.
thank you.
Yeah.
Um, all right, we have a question on YouTube. Somebody's asking, how are the long-term effects of microdosing compared to SSRIs for generalized anxiety disorder and depression? Which would you recommend?
I am so
Uh,
tempted to give a long response, but I'm going to give
yeah,
a short response, which is we don't know full stop.
mhm.
Yeah, like I don't want to give advice. We don't know. No one's done
That's
this,
true. That's right.
but it's a really good question, and someone should do that.
Yeah. With Yeah, I guess there has been studies comparing high doses with SSRIs for
Yeah, but long
depression,
term,
but
we don't
long
know.
term now.
Like we asked people for, so our participants also we followed up with them for 4 weeks after the last therapy session, or sorry, after the last experimental session. And then we also follow up with them there was a separate study where we asked people if they're willing, We'll follow up with them every 6 months for 2 years. And we're still doing that right now. But we don't know about the side effects or like, and we don't like people microdose for 8 weeks. So we
Sure.
don't know.
Okay. Well, thank
Mhm.
you for the question and thank you for the answer. And anybody else has any questions? Oh, well, I guess we could wrap up. Thank you so much, Rotem, for coming here and giving a presentation of your wonderful work.
Yeah, my pleasure. Thanks for inviting me. And yeah, thanks for being such great, engaged people. Like, yeah, I like talking to people way more than I like presenting. And thanks for coming in and making it feel like a conversation.
Yeah, no worries. Thank you.
All right. Take care,
Thank
everyone.
you. Have a
Bye.
good night.
Thanks so much. Take care.